Move on. Okay. So our last presentation for this morning will be from Dan Massey and Rex Chisholm, his co-chair, talk about challenges in integrating electronic health records. Thanks.
So as the designated EHR geek, I was instructed by Rick to go fast. That's the most important attribute of the last presenter for the morning, and so I'm going to go fast. And in the spirit of heterogeneity, you're going to see yet another presentation style of a work group as soon as I see my slides, in the sense that what we're going to do is go through each of the elements of our white paper, and I will stop briefly to ask the designated lead author on that topic to enhance what I'm going to present very quickly here. You see the names of the group. Their bios are available in the attendee list, so I won't go through those now. The context in which this occurs is that electronic health records, a superset of electronic medical records, which EMRs do have this connotation of being something that providers created, where health records have a much more holistic and inclusive view that observations provided by participants, their family members, sensor data, other linkable data types would be included in the definition of those health records. But we know already from NIH-supported work that they have the promise and the demonstrated capacity of supporting both discovery science and improved healthcare process and outcome. The strengths of these classes of data compared to traditional kind of research cohorts are that they inherently are longitudinal, and increasingly we will see lifelong longitudinal records extending across generations as a byproduct of the infrastructure that is now in place. In addition, they have a sort of a real-world view where if each of us truly is an experiment of nature, but it isn't just nature, right? It is an experiment of personal choices, an experiment of environment, of health decisions and interventions made by healthcare organizations and providers. So that clearly makes us unique. So this ability to find statistically valid cohorts in what are inherently a sparse matrix, rare variant landscape is something that they could support when we include millions of records. This technology is now past the tipping point, and in the US, we have essentially 100% adoption by hospitals, over 85% at outpatient practices of the core technology. And we have a set of drivers that is a federal certification process for these technologies that essentially makes a set of functions that they provide part of the contract for receiving federal reimbursement for healthcare. So with that, the 5 elements of our white paper, the 5 topics, that some of which are challenges, others are opportunities, are listed here. They begin with a decidedly non-technical topic, and that is motivation to participate. The clinical data is jealously guarded, and it has legal restrictions on it that make institutions unlikely to share as the default proposition. So we've got to overcome that by having motivations both for institutions and individuals to participate. And apropos of the previous discussion, there is the possibility of a technical infrastructure for finely granular consent for those who wish to give finely granular consent as opposed to block consent. The second was the issues that have been confronted primarily by some of the Pathfinder consortia, such as the Electronic Medical Records and Genomics, or eMERGE, which are addressing the issues of integration and analysis of this data arising from very heterogeneous systems. The third is we think our maybe perhaps only novel contribution, but it could be a very powerful one, and that is putting patients in control via blue button functionality. We'll tell you a little more about that. And then fourth, the issues that will be involved in successfully engaging industry, and then lastly, cybersecurity. So we'll have one slide for each of those topics, and I'll call on each of the authors. So to summarize, with respect to the value proposition for a participation, we envision three pathways. The first was, as we've already heard, the union stitching together of existing cohorts. The second is bringing new organizational partners in, that is healthcare organizations in. And the third is the direct submission of data by individuals, where I might, in essence, have the vision of joining the cohort on your smartphone and then being able to use your smartphone as the way that you route your data to the cohort. For this, it's clear that when one is talking about millions of individuals, even very large numbers, when divided by millions, get to be very small marginal cost per participant. So clearly there should be some recognition of the value of quid pro quo models, where the information generated by the project has value that it is sustaining to both organizations and individuals. The idea of operational models that centralize versus leave the data where it is and do the analysis and access to it in a federated model are important structural aspects of any system that's going to use clinically derived data. And then the idea of, as I mentioned, our ability now, technical ability to have a new consent model as opposed to the kind of sign a consent form and we're off and running with the study. So let me pause there. Rex Chisholm was our lead author on the human and business factors.
So I think that was a great summary. I would just add a couple of points. One of the things about electronic health records is they are broad and often deep, but not always consistent in the case of many cohorts where you actually are collecting exactly the same data on every participant. And so as we think about these three options of unions of existing cohorts, new organizational relationships, and direct submission, we just need to think about what the trade-offs are between having the same information on everybody versus really sort of universe of possibilities. And I think that very much addresses a lot of the discussions we've already had in terms of, should we create something completely from scratch, or is there value to these existing cohorts? And I would argue some of this data says that there's already value to these existing cohorts so that we can get out of the box quickly.
Okay, thank you, Rex. And that segues very nicely then to the issues of integrating and analyzing these data from heterogeneous systems. The major finding of the organizational experiment of doing the eMERGE consortium was that, in fact, research-grade phenotypes, if you wish to call them that, could be extracted from routine clinical data. And to do that requires a kind of a civil jury model where you have a combination of different types of data, billing codes, lab values, medications, and none of them is the gold standard. They all provide value. They all are noisy. They all are sparse matrix in the sense that the observation exists on some people but not on others. But importantly, it was also the observation of that consortium that it really needed the analysis of unstructured texts. So histories and physicals, procedure, discharge summaries, progress notes, which when concept indexed by computer programs that in essence could read the notes and add the additional structure to them, was necessary to create cohort specification logic that got the positive predictive values up into a range that was acceptable for research uses. It goes without saying, obviously, that you need to make sure you're analyzing the data from the right person. This is deceptively hard to do in electronic medical records, which have error rates that are published between perhaps 1% to 5% of individuals, where a record of 2 individuals is joined, or there might be healthcare fraud or other kinds of, or simple mistakes on names and birth dates and such. So making sure that that linkage occurs is the beginning of data integrity. The data is also inherently very rich in features that support re-identification. So there is no technology-only solution to the, quote, data privacy issue. That is, it will have to require a combination of technology and policy because of no guarantees that it would not be possible to take even de-identified data and use it without risk that the person could be re-identified. And as I mentioned, this requirement of natural language processing that's been demonstrated for this research done to date is a relatively scarce skill and expertise across the healthcare landscape in the current environment. So let me stop there with the top bullets and call on our lead author, Josh Denny, to provide any additional comments.
I think you summarized very well, Dan. I think one of the key points was just that we emphasize the need to get full access to the record at some level, whether it be at the local site or not. And the challenge is to share that data and interpret it across different EHR systems using there's lots of differences between each local implementation. So there's a dearth of experts to mine that data at each site.
Thank you. We'll move on to the next in our novel contribution to this discussion, which is for those of you who are unfamiliar with Blue Button. It essentially began as a kind of media campaign of the Office of the National Coordinator. But the HIPAA high-tech legislation gives individuals rights of access to electronic copies of their data. And the Blue Button campaign encourages individuals to do that. And it also encourages, as part of the meaningful use criteria, EHR vendors to build that into their systems. And you see it implemented these days as a variety of patient portals, as well as this relatively narrow specification that essentially has defined several data objects, if you will. One's a document, a clinical summary. Another is an explanation of insurance benefits. What our work group envisioned was a version of the Blue Button that we're calling Sync for Science, the S4S button, that essentially enables an individual to download their data to their web browser or device, and then securely exercising their right that they can redistribute that however they wish, send that data to the data center directly, and with their own click of the button, be an active agent rather than a passive agent who's consented for something that someone else did. They actually are sending in the data themselves. It has the additional property that if there's some kind of a viewer for that, they can actually see that it is their data before they decide to send it forward. Now, to get there, additional work is going to be needed to add additional data types and formats, and to work with EHR vendors. And so let me call on Doug Fritzma, who was the principal author of that section.
So thanks so much, Dan. I think this is really an opportunity for us to change the way in which research is conducted by engaging patients as first-order participants in what they do. There are other opportunities that I think will bleed out of the precision medicine and help other aspects of the clinical care. New apps and innovation to help clinical care delivery. The notion of data portability, it's currently not possible to extract your information in an electronic format from one electronic health record and import it into another. And I think, as you mentioned, the notion of improving quality of the data, who knows the data better than the patient and can actually go through and make sure that it's correct. It's important to note that Blue Button started as a campaign, and it's not a single specification, but a collection of specifications. Most of them are document-centric. And so they have care summaries, they have explanation of benefits, discharge summaries. And I think for precision medicine, we need to move beyond document-centric views of data into data-centric views of data. The good news is that a lot of that work has already started. There are underway specifications to define highly granular data in a consistent structure so that you can kind of impose different definitions but have a common structure so electronic health records know how to interact with that. Specifications for creating a container, and I use the word container rather than document, where you would put this data. Think case report forms that you can put a lot of questions and other things like that into them. And there are new standards that are being developed that leverage the existing kind of modern specifications that are very mobile and very cloud-friendly and different than what has been done in the past. That helps us with the structured piece, but we have to make sure that we don't let perfect be the enemy of good. And I think one of the issues that are going to be important is to be able to extract from an electronic health record the entire medical record in all its glorious heterogeneity. And trying to develop that specification, there are, again, some of those building blocks, but it will take sort of this community to push those things forward as we go forward. The last thing I'll say is that it will never be a one-size-fits-all for any of the patients, and we have to be able to accept a certain degree of heterogeneity. We will get there iteratively, incrementally, by not letting perfect be the enemy of good, and by charting a path, like I like to say, the path of least regret as we move forward. Because it isn't going to be perfect when we start, but we want to be able to move towards a place that's better.
Thank you, Doug. And now then move to our next topic, which was industry engagement, and is based on the observation that this cohort will depend upon engagement and support from commercial vendors. And to date, clearly, research use cases have not been prominent drivers in the creation of the functionality that are electronic health records. So that the industry engagement needs to have the 4 features that you see there. Practical, specific, it has to be certifiable in a kind of engineering sense, you know exactly what it's supposed to do. It should leverage existing government EHR requirements, have objective and transparent measures of success, and be technology agnostic, that it doesn't favor one vendor over another. And industry goals shouldn't just be some dry technical specification. They should include delighters. And so for further explanation of those, I'll turn to the lead author of that section, Sachin Ketterpal.
Hi, my contribution to this team, I think, is the weird perspective of somebody who started out as a small business person, got acquired by General Electric, and then went back to academic clinical medicine and has lived several different lives. And I think one thing we've learned in that process is that when we look at industry, it's unfortunately sometimes with a suspicious eye that each feature or functionality or engagement involves a financial change. And the blunt reality is that no matter what we do here today, no one's going to go search on Google more often. Apple can't sell any more iPhones. It's not possible. They're making them as fast as they can. And so we shouldn't think that each of these plays by industry is a way to get another buck out of their customer. Oftentimes, industry is just looking for a way to make their existing customers happier. Epic is installing as fast as they can, and a lot of what they're looking for is ways to just make their existing customers happier, and that's a really vital role here when you think about the sites themselves. And those 4 recommendations are about the successes we've had in a multi-center group, about not giving industry us to play off of each other. Historically, what's happened is different physician groups, different provider groups, different research groups come up with different standards, and as a result, industry can't pick any of them, and therefore they just throw their hands up. And it's about this group taking these philosophical differences, picking one, saying that's the definition, and then transparently measuring industry. How many patients have been enrolled through the Epic research portal? How many patients have been enrolled through the blue button functionality? And making that transparent, making that invisible, so that industry sees the value of participating, and industry can demonstrate to their customer base the value of being part of this initiative.
Okay, thank you. And we'll go then to our last topic, which I think is we are ending on a somewhat somber note, and that is cybersecurity. I guess it's appropriate since the announcement of the new Federal Office of Cybersecurity was made within the last 24 hours. But it's the realization that data for research in this cohort will arise in part as originally having been born as PHI in a HIPAA-protected covered entity. And so it is obviously highly sensitive personal data. And it's not about data security only. This is a very communication-intensive enterprise, so communication security, because it will involve digital telecommunications networks, the internet, smartphones, other network-connected devices. The simple reality is cyber attacks on healthcare data are increasing and will remain a persistent threat. It is a battleground out there every single minute of this current environment. And so, as it's said about aviation, it's an activity that's not inherently dangerous, but it is highly intolerant of error. And this will be a cohort whose technical infrastructure is not inherently dangerous, but it is highly intolerant of error, particularly with respect to cybersecurity. Now, the work group, having observed that, also believes that there is no project-specific data and communication security technologies that have to be developed just for this project, but maintenance of state-of-the-art cybersecurity will be essential for every single step of the process to the cohort. And with that, we're done, and And our time is done as well, so we'll take no questions. I don't know, Rick, do we have time for a few questions? All right, yes.
Is
You're
this
first.
on? Hi, Andrea Downing again. I was looking for one thing from the perspective of a participant, and I didn't quite see it, and I might have missed it, but when you're framing the security piece to participants and going through the informed consent process, we are giving everybody like a very clear explanation that they can be re-identified, right?
Yes, I think
Okay.
that clearly there are different forms of how that representation would be made. But this data is so rich in features and so rich in characteristics where it is not in itself identifying, but it can be linked to data that makes it identifying. So I think the idea of anonymization is an interesting construct of the 20th century. Certainly does not apply in this environment. And so accepting some non-zero risk of re-identification is almost certainly going to have to be part of the contract for participation.
Yeah, I absolutely think we have to explain that in very, very clear terms to people. It concerns me out of everything that we look at and bringing participants on. They're taking a lot of risk. And, you know, I think we have to be very clear about that. One other question, what is your thought about separating out Social Security numbers from this so we don't attract people like data breaches, like the Anthem hack that just happened?
Well, so there are a number of high re-identification data tokens that would need to be at least highly separated. The use of Social Security numbers as medical record numbers, one would hope, has been long since abandoned, but we know there are systems where that's not the case. And so we'll have to confront these issues of natively high hacker potential data items. The good news is that there are technologies to deal with all of those things, and they'll need a very thoughtful implementation in this cohort. But to return to your previous question, I think it is part of the contract that the inability to give a guarantee that you will never have experienced something that might re-identify you should suggest that there'll be a group of people who simply should not join this cohort because their personal concern about that would take precedence over their willingness to participate. Dixie.
I had two comments, neither of which has to do with security. The first one is Blue Button, the second generation of Blue Button. You referred to Blue Button. The second generation is even more applicable to this project than the first because the Blue Button Plus, which is second generation, includes OAuth 2, which actually enables a mobile app to query an electronic health record and pull data. It's not just the individual pulling it down. So it will be even more, and it already is a standard. The second thing is that the comment about EHRs being interoperable, they're not interoperable, although that is a high priority moving forward, but today they aren't. But there is a new standard being developed by Health Level 7, HL7, that I think is extremely important to this initiative because for defining the new resources that we will want to be including in an EHR. Because the EHRs don't know about some of these novel data sources. And I would encourage this initiative to engage with HL7 soon on what they call the fast healthcare interoperability resources, FHIR, F-H-I-R,
yes,
to define FHIR resources for these novel data elements as well as profiles for accessing them in restful ways.
Thank you.
Yes.
Yeah.
We out of time. One more question.
Okay, very quickly.
George, where are you?
I'll channel George. We had a session here yesterday in another building on Alzheimer's disease in which people were bringing in electronic medical records and discovered that 40% of them did not have a diagnosis of Alzheimer's disease in people with the illness, which brings up the quality question. And it might be helpful for us here to just get a feeling for, in 2015, how many Americans have an electronic health record that would be ready to use in a research format? Are we talking tens of millions, millions, hundreds of thousands? Just a sort of ballpark idea of where we're at. Because I think a question that keeps coming up at each of these sessions is, are we ready to do this, or do we have to do some innovation and some development before we begin to have the data that we need?
So I think the answer is probably in the tens of millions, and the experience of eMERGE, which was completely unexpected, was that this ability to use multiple classes of data, both the billing codes and the structured things, which may lead you to the wrong diagnosis, but when combined with lab values, medications importantly, and natural language processing of the clinical notes of providers, does sort of elevate a relatively noisy and unruly gaggle of data so that it has real value. Now, what you can't do by and large is good statistical epidemiology, right? Because you can't get the denominator, right? As we say in electronic health records, the absence of proof is not the proof of absence. So the fact you don't have a diagnosis of diabetes doesn't mean you don't have diabetes unless it's been looked for. And so there are a set of techniques that can be applied to this noisy data to reduce the problem you describe of misclassification, misdiagnosis as it exists in a coded term. And our expectation is that with the EHR infrastructure, that the volume of data and hopefully the quality of it also will sort of improve steadily over time as an environmental factor that this project does not need a priori to drive itself.
Great, thanks. So we have a question from the web. I think this is a question that comes up a lot, which is how participants in a research network like this would actually be able to see their EMR. So this person asks, how will EMR and social media coexist in moving towards a customizable user experience?
So I think the correct answer to that is anybody? Does anybody know? And stay tuned. It'll happen. What happens will happen. Rex,
Yeah, most, and it's increasingly used, most electronic health records have a patient portal, and in fact are being widely encouraged to use the patient portal. At our place, we're now up to about 40% of people that are actually accessing their lab values and information through the patient portal. And as I'll talk a little bit more about this tomorrow, but we've also using in a very proactive way in terms of having implemented, for those of you here that are familiar with the PROMIS toolkit for quality of life surveys, we've actually implemented that in the EPIC EHR portal that we have so that participants can actually weigh in on their own quality of life, but using that structured tool.
And the other part of that, though, is, of course, is someone going to download their medical record and post it to their Facebook page? And the answer is, well, sure. It's the society in which we live. So I think any class of data that we might consider sensitive might not be, in the view of that person, sensitive, or they see more value in letting other people look at it than in protecting it. So that in encountering this kind of Wild West landscape of unexpected personal behaviors is, I think, just going to be part of the adventure. Enjoy the ride.
Thanks, Dan. So that brings us to the close of this session. I would like to thank all of the presenters and in particular the participants in the audience. I thought it was a terrific beginning of a discussion, and I'd like to suggest that we take a 15-minute break, be back at 11:35, and we will start promptly no later than 11:40. Thank you.